Good morning, good afternoon, good evening, depending on where everyone is. But it's great to see all of you and see many of you. I see the numbers are slowly rising up, so we'll give it a couple minutes while we give some time for people to log on. But really great to see so many people logging on for the first of these, or the second of these two webinars, the first of 2025. So happy New Year to everyone, and happy Chinese New Year to those who to celebrate that as well. But like I say, it's really a great honor here and a great pleasure to have Dr. Eddie Knopp back again for the second of these webinar sessions. The first one that he did back in October was incredible and incredibly well received. So we certainly are thankful to get some of his time again and have him come back to go through a couple more cases that have been presented, as well as the final ones that were didn't quite have time to get to on the first one. While we're waiting for more people to join, I think everyone has access to the collection of cases that Dr. Knopp will be drawing from. But if you don't, we've put it into the chat, so people who are part of Unity can easily hop up there and click on the link and open up the cases in their own web browser. If you're not part of Unity, that's your own fault. And but send us an email and we can always get you a quick account set up. Perhaps not for today, but certainly for the next webinar. And you'll be forced just to watch through what Eddie's doing. But we'll certainly get you set up for the next one for sure. So drop us an email or put your name in the chat if you don't have a Unity account. Okay. All right, numbers are still climbing, but seem to be settling down. So with that, maybe I will hand over to Dr. Knopp to take it away. Again, the purpose of these sessions really are part of our outreach and training program as part of Unity. One of our 5 major pillars, obviously, was capacity building at the sites, and that was split into 2 sort of sub-pillars, as it were. One obviously on the research side and the MRI physics and really learning about MRI. And the second of those was related back to clinical radiology and really trying to assist groups and trying to understand the images that are being acquired, really get a good sense for high quality images versus low quality images, the different types of artifacts that might be present in some of the images. As well as what different pathologies might appear. And so while this is certainly not a clinical read session, as it were, certainly we're not getting full diagnostics here, but the goal here really is for Dr. Knopp to kind of walk through some cases that he's identified that have been submitted by various members of Unity, and just give his opinions and thoughts on them, and his overall clinical opinion, as it were, as opposed to a pure diagnostics. So again, really, really happy and great to see so many people involved today. And like I say, I'll hand over to Dr. Knopp and I'll be quiet. Thank you so much again, Eddie, for doing this and for taking time out. I know your time is incredibly valuable. So, but over to you. Thank you.
Thanks, Sean, and thanks, Steve, and the whole Unity team. It's great to be back again. And one little announcement kind of on my part, we're going to go through some of the cases that were submitted, those with pathology. If anyone has any clinical information or insight about the case, please just shout out. I'm used to being yelled at and shouted at, whether it's my grandkids, kids, or my wife. So feel free to join that bandwagon. Likewise, if you have a clinical question or a question related to something you want to see, as opposed to something more technical, shout that out too, so we can address whatever your clinical needs are. So with that, let me share my screen.
And I think, Eddie, the first one you were going to start with was the Ghana, the Corlebu.
Yes, that's correct.
Perfect. So if there is anyone, and I don't have access to the full list of our attendees, but if there is anyone from Corlebu, please feel free to come off mute. And if you want to give kind of a history of the data, when it was acquired, age, etc., that would be great. If not, we'll roll through. But give a couple seconds if anyone's from Corlebu to speak up.
So this is a case that was obtained on December the 19th of this past year, and the indication I have is incidental finding. And clearly, when anyone's looking at any sort of imaging, you can see things that are unexpected. and need to be addressed and want to be addressed. So I guess no one's here. So with that, why don't we look at some of these sequences and realize what we have. Again, the sequences, like Sean said, this is not for diagnostic purposes, but more for educational purposes, as some of the sequences are limited, some of the sequences are specific, and not typical clinical sequences that we would do even using a swoop scanner here in the United States. With that being said, I'm just going to organize this a little bit so we get a sense of what we're looking at. And we're going to go through, and I'm going to make it larger to make it easier to see the images. This is a fast sagittal T2, so it's lower resolution. We can see it's a T2. We can see there's a brain. We can see there are globes here as well. But what we also note is maybe something looks a little unusual in the posterior fossa. So let's take a look at an axial image. This is an axial T1, and it's the T1 standard. So it's kind of a flat turbospinecco type image character. And starting at the top of the brain, coming down, we see ventricles. There's a septum pellucidum. Cortex looks okay. And as we get into the posterior fossa, we're starting to see an abnormal appearance and configuration, and not something that we would expect. Typically, we like to see cerebellar hemispheres bilaterally. Here we have the inferior brainstem and the medulla, the inferior aspect of the fourth ventricle, but dorsal to that, so behind the fourth ventricle, something's missing. Something is not there. And I believe that's what caught the eye of the clinicians in Ghana at the time. And as we come higher up, we can see now all of a sudden, we're at the very top of the fourth ventricle. There is now more tissue here. And if we look at another sequence, that's T1 standard, we can look at a flare sequence. And we'll start at the top again. Let me window it for you. As we come into the ventricles, again, the ventricles have a normal appearance. The cortex, for the most part, has a normal appearance. There is some motion on the imaging sequences. Realize on flare imaging, on current iteration of the Hyperfine swoop scanner, you will see normal increased signal in the dural venous sinuses. Normal, not to be concerned about. Again, we see this extra CSF collection within the posterior fossa. So in dealing with something like this, one has to consider, is this pathologic and of clinical consequence, depending on how the patient, or in this case, child, is presenting, or is it an anatomic variant, which it clearly may be as well. So they're basic in the inferior posterior fossa, in the midline. There are basically two primary things in our differential diagnosis. One would be an arachnoid cyst, so a cyst that forms between the arachnoid membranes. Basically, it's trapped CSF that can have mass effect and clearly can push the brain parenchyma. And depending what it's doing, intervention may be needed. If it's pushing the brain parenchyma significantly and the child is young, you may want to decompress that to allow the brain to normally develop. The key difference between that and an anatomic variation is the imaging appearance. There's a spectrum of anatomic variants known as Dandy-Walker malformation, Dandy-Walker variants, which basically is a lack of normal development of the inferior aspect of the cerebellar vermis. Now, the cerebellum is comprised of cerebellar hemispheres, and in the midline is the cerebellar vermis. And what we see in this case, up above, it looks like, okay, there's a CSF density that's pushing the brain. On this one image, can't quite tell what's going on. But as we come further away, we can see that the cerebellar hemispheres are somewhat displaced and splayed. There is nothing in the midline going all the way down to the foramen magnum and outside of the skull. So this imaging appearance is consistent with the Dandy-Walker malformation, which is hypoplasia or aplasia of the inferior aspect of the cerebellar vermis. And it's an basically anatomic variant. Depending on how the child or patient is presenting, they may or may not need therapy. If they're asymptomatic, therapy would not be advocated. I had a neurosurgical colleague, one of the former chairmen of neurosurgery at NYU, who had said, you can't make an asymptomatic patient better, so don't do anything. And that's truly the case. I don't know if this child was asymptomatic or not, but the things to look out for are, is it truly a Dandy Walker variant, as we see here, with splayed cerebellar hemispheres, communication of this CSF density to the foramen magnum? But that in and of itself, because of displacement and an upwards displacement of the little piece of cerebellar vermis, may cause other problems. It may cause obstruction of the ventricular system, in which case you'd want to treat it. Here, the ventricles mildly prominent, but not to the point where we would say there's obstructive hydrocephalus. So I think that my recommendation for this would be to follow this child, provided that they're asymptomatic. Does anyone have any questions about this incidental finding? That's what was indicated clinically as a Dandy Walker malformation. Okay, I'll take that as a no. We
Perfect.
can go to Sean.
Well, before you sneak away, Eddie, and this might be completely out of your wheelhouse, but do you have a sense of, what might be, if they were symptomatic, what would be your thoughts of what would be most likely to be a symptom? Would it be sort of headaches or some sort of sensory motion
Okay.
issues or?
So with anything in the brain, symptoms are going to be a manifestation, reflection of where the problem is. So first and foremost, if this was causing hydrocephalus, we would typically expect to find symptoms of hydrocephalus, headache, some gait disturbance, and the like. There isn't hydrocephalus, so I wouldn't expect that. So then we need to think, what's the role of the inferior cerebellar vermis and cerebellar hemispheres? And that tends to be coordination and gait as well. So the child may have an abnormal gait and may not have as much coordinating skills as one would normally expect for their given age. Again, if anyone from Ghana is on and they have a little more clinical insight into the patient, that would be great. Guess not.
Yeah, maybe a second. I know we have some people from Kintampo, but if they have the ability to say this is theirs or if this was in fact Corlebu.
I believe it's Corlebu.
That's what I thought
Yeah,
too.
Saw that somewhere, someplace.
Yeah, Jess thinks it's Kintampo, so another K, but the same country. So, yeah, I'm not sure.
Okay.
Okay, well, if not, you can always reach out afterwards, and I'm sure we can, update it in the description as well.
Oh, it's definitely Kintampo. Here we go. And if you can't see the chat, guys,
Okay.
Chris chipped in to say if the child is very young, you can monitor head circumference to make sure it isn't growing out of keeping with a normal trajectory. And this is from Kintampo. So are our Kintampo colleagues available to speak up? It would be great if they could for 1 minute about symptomatology. You're too shy.
That's right.
Maybe put
Okay.
something in the chat later. Oh, so there we go. So I think it's, come on. So Magnus Philip Spencer can say something. Come on.
Yeah, I just need to allow them, Steve, to talk. Just bear
Oh,
with me
good.
one sec. Yes.
All right, stick with us. So you're probably trying to say something, and we didn't realize you couldn't. Give you a couple seconds. Well, as you say, hopefully this kiddo is asymptomatic and doing just fine. And so have you seen cases like this, for example, Eddie, where, it is just, stays medically insignificant, kid does fine as they get older, and, every time they get a scan for research, they'll be flagged for an
Or
incidental.
even worse, mild head trauma or something, which
Right.
typically, at least here in the United States, is how things tend to come to pass. The kids in school, they're playing soccer, they hit their head or something, get a CAT scan, and it's like, oh my God, what's happening there? Then
Right.
get the MR, and the kid's perfectly normal. Maybe they're in high school, maybe they're in college.
Right.
Totally unrelated.
Right. After we give the parents a stroke. Yeah.
Right. But we could image that too.
Okay. It seems that we
Hi,
might have.
Ron.
Oh, here we go. Perfect. Thank you.
Yes. So we are trying to measure from time to time the circumference of the baby, but in the pregnancy, what the mother said was the mother had a fall, but I don't think it's probably related to this. So what we are trying to do is from time to time you measure so that you see some this growth in circumference.
I didn't quite get all of that, but I did catch one word which will prompt me to a little discussion, and that was pregnancy. So depending on the utility of fetal ultrasound and prenatal ultrasound, this may be detected as well. It's obviously fluid, and you can see that on ultrasound, in which case the recommendation at that point would be image the child after they're born and then follow them accordingly if you pick it up in utero.
So during the ultrasound, when they checked, they said it wasn't visible. There was nothing wrong with the fetus, but when we did the MRI, that was when we realized that this is a problem. But when they did the ultrasound, when the mother fell and they did the ultrasound, the fetus was good, the baby was good.
Okay.
I can jump in here as well because I've spoken to the Contempo team. Thank you, Ken and Philip, for submitting this case. I think what Philip is referring to is that there was some concern from the team as the mother had reported a fall during the pregnancy.
Oh,
But after reviewing the scan and coming to the conclusion that it looked like Sandy Walker syndrome, we confirmed that this is congenital rather than being due to a fall. And Ken has reported back to us earlier this week to say that the baby has been seen by doctors at the clinic and is being referred for a high field scan in Kumasi for clinical follow-up.
Great. And do you have the age of the kiddo? It looks like it's like 3 to 6 months, Jess. Is that about right?
This is a 3-month-old baby.
Perfect.
Thanks so much for the feedback, Dr. Knopp, and thanks, Contempo, for submitting it.
sure.
Yeah, great. It sounds like there's lots of work being done on the kiddo back in Ghana. So that's great. Awesome. So wow, this was off to a great start. Lots of discussion, different comments coming from different folks in the chat. This is awesome. So let's keep this momentum going.
Yeah.
And Eddie, if you want to hop on to the next one, that was
Fair
great.
enough. So why don't we keep in the theme of CSF and ventricles? And we're going to look at this case, which is a 13-month-old hydrocephalus post VP shunt placement from Cape Town. And if anyone from that site is on, please provide some clinical information while I open up the case.
Yeah, I mean, certainly we have Jess that was just speaking, but I think Christy is on if she.
Yeah, Kirsty's here as well. And if you put your hand up, the Collective Minds team will unmute you so you could speak.
I am, but I am not familiar with this. Was this one of our cooler babies? I think this was one of the cooler babies.
The
So
child did have a ventricular peritoneal shunt placed.
Yeah, this was one of the cooler babies
Cooler
cases that
babies,
came from
yes.
a while ago. I don't know if
Yeah.
Liv on the call, I think she submitted this one.
So we do have a couple of children from the cooler cohort, which is also just a population birth cohort, who had abnormal scans, and this child, in fact, had, if I remember correctly, there was anxiety about increasing head circumference. And it was obviously picked up quite early and and we were able to get clinical scans and rapid referral into a tertiary children's hospital where she could have the intervention. Apologies, I was just like trying to think back because this was like 4 years ago. So yes, indeed.
Okay, do we know if there was any intracranial infection, meningitis and the like, as a potential etiology for the ventricular enlargement?
No, no, I actually think this was considered congenital,
Okay.
as I know. Yeah.
Okay,
I
so let's
don't
look at this
think we
case.
have had any children with meningitis who we have diagnosed, or with sequelae of meningitis who we've diagnosed by incidental finding on the MRI scan. Obviously, we have a much higher rate of infections here, such that congenital infections and intrauterine infections are much higher. There's also approximately 30% prevalence of HIV infections in the mothers, the children, but it puts the young children at higher risks of infections as well. But I think this particular one was considered a congenital, even if it was a secondary cause in pregnancy.
Okay, so let's look at this case and it'll become apparent why I was asking that specific question, because typically when dealing with hydrocephalus or ventricular enlargement, it tends to be a more uniform diffuse enlargement of the entire ventricular system, such that when being treated with ventricular peritoneal shunt, there's free communication amongst the ventricles, and placing a shunt, let's say, in the left lateral ventricle will allow drainage of the entire ventricular system. Now, if we look at this child coming from the top of the brain down, we'll use T2 weighted imaging. It's easy to see the ventricles filled with CSF, white signal, and the brain is dark. So as we come down, we start to see that there's some abnormal CSF collection in the region of the right frontal lobe. It looks like the interhemispheric fissure is a little more prominent. Maybe there's more CSF in there as well. And as we come more inferiorly, clearly the ventricular system is abnormally enlarged. This is the shunt catheter itself. Doesn't give any MR signal. It's just silastic and silicone-based rubber, and it's entering from a posterior burr hole going into the left lateral ventricle, looking to cross to the region of the septum pellucidum. Normally, there should be free communication between the right and left lateral ventricles at the level of the foramen Monro, just above in the roof of the third ventricle. So if you were to drain here, this should drain as well. But as we're looking, what we see, excuse me, is the ventricles are enlarged with kind of an abnormal configuration. And I'm also seeing these dark structures, or what I would call septa or membranes, within the ventricular system itself. Those tend to be hallmarks of prior intraventricular infection, and you kind of think of it like a scab within the ventricle, kind of like a web, and it causes loculation or blocking of the ventricular system itself, which can cause a big problem to the surgical approach of these children, because now, as opposed to putting in one simple ventricular catheter to drain the entire ventricular system, you would have to drain different components of the ventricular system. Here we see that the left frontal horn is normal, the right is abnormal. Posterior ventricles, both left and right, are abnormal as well. The temporal horns are markedly enlarged and not being drained, and there's an additional fluid collection here in the posterior fossa. Now, remember when we were talking in the last case about Dandy Walker, how things were splayed, and a differential would be that of an arachnoid cyst. So a focal extracerebral collection of CSF within the calvarium trapped in the arachnoid membrane. That's what this looks like. It looks like it's confining to maybe a particular region, the foramina luschka, and expanding. And I think this is all due to blockage of the normal flow and pattern of ventricular CSF, most likely on some form of infectious etiology and basis. So when looking at children, or any patient for that matter, that's being treated for hydrocephalus that has a ventricular peritoneal shunt in place, there are certain things we want to look for. We want to make sure that the ventricles are decompressed appropriately. And that might mean you still see some CSF fluid uniformly in the ventricular system. If you don't, what's known as slit ventricles, you don't see any ventricles, well, maybe that child is being over-shunted and too much fluid is being taken out. In addition, you want to look for the presence of fluid outside the brain in the subdural space. If it's mass-like, then that's going to have to be treated. And following the insertion of the shunt, you want to make sure that the ventricle is drained and there aren't these loculated areas of trapped CSF, as we see in the frontal region, we see in the posterior fossa, and the ventricles are not adequately draining. So I don't know how this child presented or is currently presenting, but it's kind of a complex problem in how to deal with this, because you want to decompress the ventricles to the extent that you can so the normal brain can develop and the child will make normal milestones. The enlarged ventricular system compresses the brain parenchyma and cerebral cortex, and that could lead to a significant developmental delay, not to mention symptoms, again, primarily would be headache, and maybe some incoordination and gait disturbance.
Great. Yeah, thanks so much, Eddie. Is there any questions from anyone on this case? This is one of those nice instances where it's super easy to see, which is always useful.
Right. No question.
Yeah, you know, even I can see these abnormalities. I don't know what they are, but I can see them, so that's always useful. Maybe as we're going along, I did notice a question from Patricia from Kenya in Nairobi, who is asking, and this is kind of a general question, so I don't know if we'll spend time directly answering this out loud, but certainly I think there's enough people from their experience who can put things into the chat of how to ensure you're not creating anxiety among parents when you deal with sort of these abnormal results. So when you see these sorts of things popping up, you get a clinical opinion on them. How do you not create anxiety in the parents? And that's always a challenge anytime you have an incidental finding, because you're going to want to talk to the parent about what obviously what history they might have, how is their child doing, etc. But I'm wondering if you know, Kirsty, I know there's a number of people on the call who are actively involved in research at Sidra, etc. Might want to take a second to say how they would sort of deal with these sorts of things. And how they would interact with parents.
I'm fine to talk about this, Sean. So I think one of the challenges of doing population level research is that the expectation is always actually that the babies are healthy and fine, and so when you find something unusual, be it a heart murmur or something unusual in the, a club foot or a hernia or indeed a brain scan, we have to be able to respond to it in a responsible way. And because we are particularly in these studies focused on development in the brain, we it's very important to have systems in place and standard operating procedures that connect our research studies with established clinical services, and to be able to do appropriate investigations if further investigations are needed. And in this case, the child was referred for we didn't. The child was diagnosed obviously prior to the scan because she has a shunt already, but balancing like you would any other time information about what the prognosis about the condition is, exactly what to expect, and that can be difficult within a research team when you don't have the relevant clinical expertise. So building relationships with other clinicians is really important to be able to kind of build rapport, and so that you can give families as much information as possible so they don't feel like they're being just sent off with a sort of 3 or 4 month wait while they don't actually know what's going on. So that's often where the disconnect between research and clinical services can be tricky.
Great. Yeah, that's an awesome bit of insight, Christy. So and looks like you got the second thumbs up from Sidra as well. So hopefully that helps, Patricia. If not, certainly we can have a discussion about that maybe on our upcoming all partners call next week, actually. So definitely something that's useful. But we'll merge back to what we were originally talking about here. Again, making use of Eddie's expertise and time, and maybe move on to the next case. Eddie, this was great.
Sure.
Thank you so much for this.
I think the next case is a fascinating case, and I truly hope that someone is on with clinical experience for the child. It says from Ghana, questionable meningoencephalitis, cerebral edema, spelled the non-American way. We'll leave it at that. And this, to my eye, looks like an older child. The imaging is of slightly better quality, easier to see things, but there's a lot that's going on. So first, is there anyone who knows anything about the child?
Yes, this might come back to our Contampu site potentially. So I don't know if Ken or anyone else from the site is still on.
And this is from October the 10th. That's the only thing I know.
I think this might be the Callaboo site,
Oh.
as far as I remember. Sorry, I think maybe the two sites
We'll get it right next time. Yeah.
Sorry.
It's a 50-50 chance and we're still
Contemporary's
failing.
just scanning babies at the moment.
Haha.
Okay, so maybe we don't have someone on who can talk to this, but nonetheless, I think we can all learn.
Okay, fair enough. So let's look at this. So just looking in general, we see that there's significant abnormality throughout the brain parenchyma. And let's blow it up. And I'm going to go to the flare first, because for me, regardless, that's the money shot. It tends to be our best sequence and gives us the most information about pathology as well as anatomy. And what we see, and let's start at the bottom. And again, remember, dural venous sinuses are going to be bright. That's not pathologic. It's not something we need to be concerned about, but we're seeing abnormal increased signal on flares. So that means there's increased water, there's increased pathology that seems to be on the surface of the brain. So that's involving the cortex. As we come higher up, we can actually see that indeed it is the cortex with finger-like projections or fronds of the intervening white matter within the gyri. And the sulci you don't see because they're being compressed. The ventricles are visualized. CSF is normally suppressed in the ventricular system. But this seems to be just on the outside of the entire brain, a little asymmetric in some areas than other areas. Centrally within the brain tends not to be affected on this instance, and that's on the flare. If we look at the T2, and there's a coronal T2, so let's look at that, we get the same sense, and you get a sense again of the uniform diffuse cortical involvement that we're seeing here. Bilaterally uniform, all within the supratentorial brain, so not the posterior fossa. And again, these gyri look swollen, the sulci are compressed. There is intervening normal white matter. So whatever this process is, it's not affecting the white matter, just the cortex. So let's think for a minute about the difference between cortex and white matter, right? So what's white matter? White matter are wires, right? They don't really do much of anything. They don't have a high metabolic demand. Whereas cortex is the action part of the brain, right? It's what's letting me move my hands. It's what's allowing me to talk, to think, and the like. It has a higher metabolic demand. So if we have a process that's involving just the cortex, we maybe can think that that's due to something in relation to a high metabolic demand that's not being met. What does that mean, not being met? That means maybe there's not enough oxygen, maybe there's not enough glucose, maybe there's not enough blood flow. So maybe something like that has happened. Typically, Other areas of the brain that have, and we're going to go back to the flare, that have high metabolic demands are within the central portion of the brain, the central gray matter. So you have the caudate, the lentiform nucleus, and the thalami. They're gray matter, and gray matter in general has a higher metabolic demand because it cells than does the underlying white matter. So if there was some diffuse global anoxic event, global anoxia is diffuse cerebral ischemia, they might be involved as well. The next thing to try to determine, is this old, is this new? We can see on the T1 that there's swelling and there's decreased signal. So it didn't happen minutes before, but rather it gave enough time for T1 changes to occur. So within a day or so, I would say. The next hallmark would be, what does it look like on the diffusion weighted imaging? And what we see is restricted diffusion. And what that's telling us is there's increased water that's present here, and that water doesn't move freely. And that can be due to ischemia, setting of a stroke. That's the hallmark of stroke. And again, it seems to be corresponding to the same areas we saw on the flare image, right? We'll go back to the flare image for a sec, right? We could almost overlay the images, given differences in technique and the like. Being able to see it on diffusion, and flare tells us that, again, it's not hyperacute, but rather an acute process that's going on. The history that I was given at the time is, again, this meningoencephalitis, questioned cerebral edema, and supposedly the child was seizing. Now, trying to connect the dots and put this all together, epilepsy and seizure foci can cause similar transient signal abnormalities that look like ischemia. If the child, and again, it'd be great if we had clinical on this one, if the child was in status epilepticus, right? So they're continuously seizing diffusely throughout their brain. That part of the brain is hyperstimulated, hyperactive, and exceeding the metabolic demands of the cerebral autoregulatory process. So you do get these flare changes, and you do get these diffusion weighted signal abnormalities, and they're all transient without a long-term sequela. So that's kind of our differential in this case. Are we dealing with global anoxia, or are we dealing with a post-ictal or a post-seizure phenomena that would be transient? There was some history somewhere that I read, I don't remember quite where, that the child, during the duration of the time that they were being evaluated, their Glasgow Coma scale normalized. So they went back to normal, which is leading me to believe, and they were seizing, so I'm going to make the presumption that it maybe was status epilepticus, that this is all a post-ictal phenomena, which it can, especially secondary to the sparing of all the other deep gray matter structures in the brain itself. But that's our primary differential. We tend to see these sort of processes and phenomena with cardiac arrest and global anoxia. Here in the United States, there was a great case great for us, not for the patient, at the end of last summer, a drowning, right? Drowning, so they lost oxygen and they were able to get the circulation back again, and they have this diffuse pattern, but that underlying deep gray matter structures were also involved as well. So that's kind of where I go with this case. I think the case is fascinating and an excellent example of the resolution that we could obtain using, the swoop scanner in the field. But again, the most important piece of information for radiologists reading anything is clinical history, because that clearly guides our differential right off the bat.
Great. That was an amazing case. Holy goodness. That's a beautiful image as well. Again,
Yeah,
I can
absolutely.
I can see those abnormalities, which is, I don't need to use the dark arts, as it were, that radiologists train for years to master. Any questions from the audience? Apparently, anyone can now unmute themselves. So you've been given the power, wield it with caution. But any questions? Looks like we have a question. Could this be a representation of cortical ribboning?
So I'd have to answer that question with a question. What do you mean by cortical ribboning? To me, it means a variety of things.
So
Sophia, I think you can unmute, so. We're not.
or maybe she can type out her.
While we wait for Sophia to respond, this takes me back 20 years. I was involved in developing a rodent model of status epilepticus and performing serial MRI changes as before, during, and after. And the diffusion characteristics and the flare characteristics echo exactly what you're showing in this case, Eddie. I know it's one swallow doesn't make a summer, but that just resonates so much with our previous work, which we then try to treat with anti-epileptic seizure treatments, of course.
And that's how, that's kind of how I put it together. So it made more sense to me with that history. If obviously you're going to tell me this kid was found down and anoxic for an hour, then different story.
Right. And Margaret, do you have a
Yeah, I have a question.
Sure.
Yeah. Would acute severe pneumonia be or cardiac disease with anoxia be one of the diagnoses? I mean, because those two again would cause anoxia.
Right. So any pathology, whatever it is, that's going to cause global anoxia for whatever reason can lead to changes like this. Again, I might expect some more deep gray matter involvement. I'm not seeing it, but nothing in medicine is absolute. You can always find the exception rather than the rule. So absolutely. And the cause,
Yeah.
severe pneumonia, child is markedly hypoxic, has cardiac issues, absolutely. Congenital cardiac disease, if they're significantly hypoxic and they're cyanotic, same sort of scenario.
And we see cases of sickle cells where they get, acute and they suffer really chronic anoxia. I don't know if this is a case of just acute, previous recent anoxia, or if someone has a chronic condition which predisposes them to low oxygenation generally, would that show like that?
Not necessarily, because again, with the diffusion positivity, we're still stating that whatever the inciting event is still within the acute phase within a week, because that diffusion is going to normalize. And if it was due to significant ischemia and tissue loss, then you're going to see the sequela of that, or volume loss and tissue loss as chronic infarct. With sickle cell disease, I've not seen, and that doesn't mean it doesn't happen, diffuse abnormality such as this.
Okay,
And,
thanks.
what I've seen tends to be a little more focal.
I
But you
mean,
might have
that's
more experience with
very-
sickle cell than I do.
That's very useful because then it will allow the clinician, even us, to know, to think of what else to ask in terms of history when we see this kind of things. But I think we should be working very closely with neurologists, pediatricians, so that we don't have to be the ones going deep into this.
I think the more history, the better. There's no history that's bad history. It may not fit, but if you don't know about it, you can't put that into your diagnostic engine and try to figure out what's going on.
Thanks.
Great. Okay, great discussion. In the interest of time, maybe I think we'll have time for maybe one more. Eddie, do you have another favorite that's there?
There's one more case.
Perfect.
I have it noted on my little list is so-so, but the so-so is because of image quality, but we can still look at it, and it's something a little different, and it's coming from Aga Khan. I don't know the exact date. Let's see. It's from, whoa, very old case, January 30th, 2022, but nonetheless. There are various signal changes. We can see image quality has changed over the past 2 years, 3 years due to software improvements, but let's make the most of what we have here. And we're going to look at, there's a sagittal T2, an axial T2. Let me put up a T1, two T1s, T1 standard and not. And let's look at the T1 standard first. There's some artifact here. You can see it's extending outside of the skull. Looks like it's some maybe metal or something. As we come down, oops, we start to see already, and again, guys, the brain is really easy. You know, this makes it easy. The right and the left, they should be the same. If they're not, something's going on. So you have to decide what side is there something going on. And right here we see within the left hemisphere, there's abnormal signal. Looks like maybe a little dark here, maybe a little bright here. It's pushing the ventricle. The ventricle should be symmetric. Again, it looks like there's something right here surrounded by, you know, some decreased signal intensity. And on a T1, that decreased signal intensity can be edema. The increased signal intensity can be blood product. So maybe we're dealing with an intraparenchymal hemorrhage with some surrounding vasogenic edema, because that's really the only way the brain can respond. Open up the blood-brain barrier, pour some edema in, and maybe get some immune cells in there to try to clean up whatever's there. Let's look at the T1 gray-white. This is an older T1 gray-white. And we basically are seeing the same thing. Looks like there's an intraparenchymal clot. There's some surrounding edema. There's mass effect on the ventricular system. We also see another area of signal abnormality here within the scalp. And maybe this is what we would call a subgaleal hematoma. And maybe this is all secondary to some trauma. This is kind of a little unusual for hemorrhage due to trauma since it's central within the brain parenchyma. But nonetheless, we're seeing the same thing. If we look at the T2, we would expect that blood clot, it's a little brighter on T1, it's going to be dark on T2. Lo and behold, it's dark on T2 with surrounding increased signal vasogenic edema. And this scalp stuff is a little bright, as we would expect, because there's fluid admixed with the blood product. And I don't know if anybody has any recollection of this patient at all, but this looks like classic appearance of an intraparenchymal hematoma, surrounding vasogenic edema. There is mass effect, slight degree of subfalcine herniation or midline shift. What else we got? Here is coronal, child's not in that well, but basically showing the same thing. On current sequences, and not this, because the image quality isn't where we want it. Let's see if we see it. Intraparenchymal hematomas will also give us diffusion-weighted abnormality, not to be confused with stroke. You have to look at everything in toto. This obviously is an old 2.5-year-old diffusion that looks kind of horrible, but we do see some signal change in it. Now, more than that, I can't make much out of it. But this looks like kind of a classic appearance, albeit the image quality is not the best, like we looked on the last patient, of an intraparenchymal hematoma in this case. Again, the fact that there's scalp soft tissue swelling on one side leads me to believe it's trauma. Typically, intraparenchymal hemorrhage and hematoma due to trauma occurs where the brain gets banged. And what's it going to bang against? It's going to bang against the inner surface of the skull. So it tends to be more superficial in the brain or the bottom of the brain. This is smack in the middle of the brain parenchyma. In an adult patient, I have no idea how old this patient is, but I'm presuming it's a child. In an adult patient, the location and etiology of this speaks very well for hemorrhage due to hypertension. And the perforating vessels in the deep gray matter of the brain, they're end vessels. And if the blood pressure goes up, well, the hose pops and the blood comes out and you get a clot. More than that, I can't dive into this.
Great. Well, I think we do actually have some of the members of the team on who can speak a little bit.
Oh, good.
Sidra, are you able to? Looks like there's even a case report on this kiddo. So this kiddo has been studied extensively. But yeah, Sidra, do you want to say something?
Yeah, so this was, I'm not the primary neurologist. This child was a 10-year-old, had severe traumatic brain injury post, I think, road traffic accident, and had a bolt in place. So our critical care team, along with Akbar Madhwani, who's also on the chat, were the ones. And then I think he made out of it with severe sequelae. But yeah, that was the first time that Hyperfine was used. Because we could not actually move the patient. So that was one of our successes in the initial days.
No, that's great. So the artifact that we see here is due to the Bolt, quote unquote, that's an intracranial pressure monitoring device. The child
Yes.
is unstable. They want to make sure that his intracranial pressure doesn't get too elevated. So they monitor the pressure with a bolt, and it basically, guess what? It is what it is. It sounds like a bolt that's screwed into the skull, and it's measuring the pressure itself. It's metal and can cause artifact on a CT. A lot of streak artifact because it's dense. On a high field MR, a lot of artifact for the same reason, due to the susceptibility. The artifact on swoop, while may be present, is going to be a lot less.
I was gonna ask that actually, Eddie. So you actually are able to scan this someone with this on a high field
Yeah.
scan.
So intracranial pressure monitoring devices are a variety of things. They can be catheters that are kind of snaked in, or there can be a physical metal piece that sticks out, and it's able to be scanned to the extent that the head fits into the coil.
Right.
So
I
in
guess
an
it's going-
adult and someone with a big head, they may not fit all the way.
Right. Cool. Well, another nice little bit that you can actually scan them on low field without a really risk of that. But interesting. Wow, great. And again, really beautiful images. Even though, as you say, the diffusion scan is a little bit older. It's just kind of early days.
A little older. Okay.
In the system. But yeah, pretty amazing that the structural scans still tell you what you want to see.
Absolutely. I'm going to stop
Perfect.
sharing for now so we can.
Great. Well, again, huge thanks, Eddie. I found this to be incredibly informative. It's amazing. I'm a physicist. I look at these images all the time, and yet you just provided a whole immense amount of flavor to these images and how they're used, which is
Everyone's work to improve image quality, sequences, and provide the clinical material that we can look at.
Yeah, no, this was incredibly inspiring, and so again, thank you so much. I think one thing that might be a takeaway for me from all of this as well is thinking through, particularly on some of our research side, if we do begin to see some of these, some of the comments you made about, particularly on, needing the flare, which is not currently part of our Unity protocol, but thinking through if we have sort of a, you see an incidental finding, do you shift to an extended protocol that would get the flare, get some of the other sequences that aren't necessarily part of our Unity scan, so that they can provide some of this additional information where possible, at least, which might be useful. Anyone else have any general questions for Eddie while we have him? Again, you can see his incredible knowledge and whatnot, so we definitely want to take advantage of having him on this webinar. Everyone's just, well, they're sending you love, at least.
Yeah.
I can see that. Oh, thank you.
Well, Calla Price at the start of the call said, "Thank you for being such a rock star, Eddie, and being so quick to respond to all of her those scans that she flags as being abnormal." So that's heartfelt across the whole collaboration.
I'm very good with email, provided given time differences. I have to be away, so.
Yeah, no, this
is my pleasure.
This has been super helpful. Again, hopefully we can get you back again next quarter, perhaps for a few more of these, because I think they are generally informative. If anyone has any comments about what they might want to see more of, what might not have been touched on but you'd like to see more of, if anyone else has any cases that they would like, obviously we have Collective Minds, so please feel free to make use of the platform and put up those images. But also send me an email afterwards, if there's something that we missed or you'd like to have just a little bit more included in these discussions, that would be great. Again, we want to make sure that they're custom tailored to your needs, and we're really helping everyone out. But if there's no questions or no other comments,
Sophia did ask about ICU, and we could request Heman Sabir from Bonn comes to present at the next one, and perhaps present one or with Eddie, maybe one or two of our cases from intensive care units that we've been collecting over the last year, and the results.
We actually could do that. I'm actually visiting as part of right before the ECR.
Oh, wow, there you go.
Stopping by Bonn, so maybe him and I can talk about
fantastic
organizing something.
I'll see you at ECR. I'm giving a talk about Unity at ECR. So there you go.
Great.
So we'll be there. We won't be. We were late to the game, so we won't be actually in the exhibit hall. but we have a space available, and obviously I'll be there and whatnot along with the team.
Brilliant.
And Fran will be there. I think you guys know Fran, if he's not on the call.
Oh, Hammond's on the call. There you
Yeah,
go.
no, I saw Hammond was on the call.
Oh, great. Fantastic.
Great. And I see Margaret has her hand up. I don't know if that's an old hand up or a new one, but feel free to make any comments, Margaret, while you're there.
It's a new hand. Are there cases where the image, I mean the scan, is showing apparent abnormalities only because of the quality? And I mean, is that something common as opposed to a pathology or an abnormal finding? Because while we were discussing, I mean, we've been engaging a few on-ground radiologists and radiographers, and when we mentioned the low field scanning, they were a bit concerned that those will not give us quality images. And then we're like, no, I think they've been used. So are there cases where it could be just a matter of the fact that we're using low field and therefore the quality could be the problem?
So the goal always is to improve the image quality. But what I tell people clinically, not on a research basis, is this is not replacing high field scanning, but it's answering clinical questions when it's either impossible or too difficult to ask, let alone get an answer to that question. So a lot can be extracted if the patient is positioned properly and they're not moving. We can get all the information we want, maybe not to the same resolution as at a high field. So we're not going to get resolution that you're going to get at a 7T and sub-millimeter. But we're going to get diagnostic quality information, as I think we can see from all of these examples. Even with motion, we're able to come up with diagnoses that fit the clinical scenario. And that's what it's about. And if high field's not available because the patient's too unstable, or it's not available because there's not one for 50, 60 miles, you're going to get an answer this way.
And I guess to extend that a little bit, Eddie, have you seen instances where we use, at least in AI speak, we use the term hallucination, and that's not true here because we're not really using AI in that sense. But do you see sort of hallucination or hyper intensities or whatnot that aren't necessarily there because of the low field? I have not seen that, but
not primarily. A couple software versions ago, you would see on the flare, and typically in adult because it's easier to see, the cortex would be a little brighter around the brain itself, but otherwise typically not. What we see is what we get and what's typically there. In some instances, interestingly, what's starting to come out, things may be more apparent at low field than at high field. Signal intensities of subdural fluid collections. If we talk about a disease that not necessarily germane to Unity, clearly not, and that's Alzheimer's disease, and patients treated with amyloid targeting therapy, the ARIA abnormalities that we see, and it's only ARIA-E edema, we can't see hemosiderin, seem to be more conspicuous, at least from some of the cases that are coming out of Washington University at low field than they are at high field. The resolution's different, but the contrast stands out a little more. Maybe there's a physics explanation that Sean and Steve can explain that flies over my head, but that's kind of the take that we're getting now.
Yeah, I was noticing that yesterday during Steve Schiff's talk, who was talking about so some of the same images that you were kind of showing today, that as you say, that fluid tends to be a little bit brighter. And I don't know if that's a T1 shift, and so you're getting some additional T1 amplification in the T2 images. I'm not sure, but I think you're right. And he was mentioning the exact same thing. So yeah, I think that's one of those interesting cases where and Andrew Webb was making light of it in the sense that he was we talk about image quality transfer going from a high quality image to a low quality image to a high quality image back and forth, and what is the high quality image in this case? In some cases, the low field image might be the high quality image.
Exactly,
right?
It may show you things with at least more conspicuity than you're seeing in high field.
Yeah, or in the case of the bolt or other implants.
Right. Oh, no question.
Right. So similar idea. Great. So hopefully that sort of answers your question, Margaret, that, yeah, we're not going to be hallucinating or making up things. And certainly, again, I think that also speaks to making sure that you're getting high quality images and then multiple contrasts so that, the story is consistent across those. But great, with that, and recognizing everyone's time, happy to sign off. Again, huge thanks, Eddie. This was really, really
Very
informative,
welcome. This
really
is
inspiring.
very enjoyable.
And thank you so much. And thanks obviously to our Collective Minds team for putting it together. Thanks everyone from Unity. We'll see you next week on our All Partners call. And thanks again.
Okay. Take care. Bye-bye.
Bye.